I've been asked to talk about biopsy techniques when it comes to breast cancer. And I've tried to actually summarize my presentation to keep it short and just to go into the important techniques. I just quickly want to start with a case study, which is a 42-year-old female patient who I saw at my practice. She was referred to me by a GP, sent to me for an FNA. This patient had a very small lump on the right breast. I was actually reluctant on performing an FNA on her, but she was very persistent in terms of wanting to know what was wrong with her. Of note, she told me that she had breast reduction in 2021. So I was thinking that it's possibly like fibrocystic disease of the breast, or it could be some regeneration going on. On examination, she had a very small lump on the right breast on the outer lower quadrant. It was very small, 1.5 by 1. It was mobile. There were no associated skin changes or nipple discharge. After trying to convince her not to do the FNA and her being persistent, I put in a needle, and the on-site diagnosis was that of C4 Yokohama, which was suspicious for malignancy. And I immediately referred her to radiology for an ultrasound-guided core needle biopsy, and we got a result of invasive breast cancer of no special type. So I just wanted to share with you this story of this patient before we go into the presentation. So when patients come to us with history of a breast lump, I mean, the first crucial step is to determine whether they actually have a discrete mass in their breast. And the discrete mass, I think the surgeons will define it much better than me. It's a three-dimensional measurable mass, which has got well-defined borders. It is distinct from the surrounding tissue, and it's generally asymmetrical when compared with the other breast tissue. And a triple assessment is the diagnostic procedure that we all know of. And this triple assessment combines clinical examination, imaging, and a tissue biopsy. And the triple assessment. Hi.
I want to confirm the slide you are on, because the one we are on, we are still on your home slide, though we could follow because you, the way you the rate.
So I'm on the...
Maybe stop sharing first, and then it might be that, stop sharing and then try to reshare.
Okay.
Let me help you to stop. Try to reshare again. Maybe it might have been the PDF document that you need to minimize, and then try to reshare again.
Okay.
Which slide are you seeing on your side?
First one.
The first one. Okay. Okay, go move once. Yes, okay, now we are with you. Yeah, but we could follow the story even if we didn't see. I thought it was part of the intro. Thanks. You may continue.
Are we on the introduction slide now?
Perfect, thanks.
Okay, so the triple test is the gold standard for assessment of all patients presenting with symptomatic breast disease. When we look at the triple tests, what is important is that individually there's 3 tests, all have appreciable false negative rate. And none of those 3 tests have been found to be 100% sensitive or specific. But when we perform them together, we can produce very good results with a diagnostic accuracy of about 100%. And it is generally accepted that about 95% of palpable malignant breast lesions can be diagnosed if we use these 3 tests together. So now this is just a summary that shows you the triple test. The first one would be your history and clinical examination. Then we have the component of breast imaging, and we have the biopsy. So today I'm going to be talking about the last component there of the triple test, which is the biopsy. Now, what is the role of a pathologist in this, in diagnosing breast cancer? So for us to have a successful, effective breast hair health program, we need to have available breast pathology, and this must be quality. Accurate tissue diagnosis is the cornerstone for therapy for breast cancer, and all women with a suspected breast mass will require an accurate pathologic diagnosis before we initiate treatment. And this is even if we have a clinical finding that is strongly suggestive of cancer. And you'll see later on why we need to do this third component of the triple test before we initiate management in this patient. And a lot of data suggests that about 20% of biopsied breast mass will be malignant, meaning that the remainder 25% are going to be benign lesions. So we first and foremost need to differentiate a benign from a malignant neoplasm. Now, the role of the pathologist is to establish the presence of malignancy. So we have to confirm that indeed the lump that we're seeing in this patient is a malignant lump. The next step is to then type the malignancy that we're seeing. It is a breast cancer. What type of breast cancer is this? So histologic typing and grading of the cancer is important. Now, I think we're going to later in the day be listening to oncologists who are going to be talking about molecular targeted therapy and tumor biomarkers. So the relevance of a biopsy is also important when it comes to determining the presence or absence of certain tumor markers, most importantly hormonal receptors, including your HER2. Molecular testing, I think earlier in the day, they've already talked about genetic testing for breast cancer. And obviously all of this is important for prognosis as well as targeted therapy or appropriate therapy. So that is basically our role as background doctors. I always say that we are the doctors in the background, and we are there to support and guide surgeons and oncologists in terms of treating these patients with breast cancer. Now, following a thorough history and clinical examination, the decision must be made by the treating clinician of what resource-appropriate diagnostic imaging will be performed on a patient with a breast abnormality and how to obtain the tissue to confirm the diagnosis. So you need to decide what imaging you're going to do and how are you going to obtain the tissue for you to confirm the suspected diagnosis. We have different biopsy techniques that are available. The options include the first one, which is the fine needle aspiration cytology, which is the one that we performed in our rooms for the patient. The second one is a core needle biopsy, which was done by the radiologist in this case. This core needle biopsies can be image guided with ultrasound or mammogram or vacuum assistant, or they could be freehand, where you actually just do the needle biopsy without the guidance. Fine needle aspiration cytology of note can also be done with an assistant radiology. Surgical biopsy is the third one, where we've got an option of an excisional versus an incisional biopsy. Now, of note, all of these techniques carry specific advantages and disadvantages, cost and resource requirements. So we need to make a decision that is guided by all these advantages and disadvantages. Now, some literature still suggests that open surgical biopsy remains the gold standard. However, other articles like your Yokohama will suggest that a core needle biopsy is the gold standard. So basically what they're saying here is that examination of the whole tissue rather than cytology would be your gold standard in terms of establishing the nature of abnormality that you're seeing in the patient. Now we need to try or attempt at all times to determine the pathology by using a percutaneous biopsy technique. That is your fine needle aspiration or core needle biopsy, whether the breast lesion is benign or malignant. And the non-invasive biopsy techniques can be facilitated, like I said, by image guidance or by ultrasound. Okay, Now we're looking at the first one, which is your fine needle aspiration cytology. So with this one, the image here shows one that is ultrasound guided. You can see the person who is performing the procedure is holding an ultrasound probe on the anterior surface of the patient's chest or the breast. And there is a needle that is being directed by the image going directly into the mass or into the area that is going to be biopsied. It is simple, it's quick, it is relatively painless. We aspirate cells using a 10 ml syringe that is attached to a 23 gauge needle, and we apply a negative pressure. It is suitable for women of all ages. It does not require anesthesia, and it can be performed freehand, or if we want to enhance the accuracy, we can perform it with ultrasound guidance, as it's seen in the image depicted here. Now, I just needed to quickly show this because we still get a lot of cytology samples where FNAs are performed by doctors in their rooms. Now, if you decide that you're going to perform an FNA in your rooms, this is how we need to do it. We don't like seeing blobs on the slides because people or clinicians perform the FNA and then they immediately just press the syringe and evacuate the material onto the slide, and then they either fix it or leave it to dry. Now, that is not good enough because your material is all clumped up in one area and it's not evenly dispersed. And when we stain the material on the slide that we received, we are unable to actually visualize the cells. And this is the reason why you will keep on getting results saying inadequate or non-diagnostic because of hemorrhage or because of poor cellular yield or dried up slide. So there are two types of smears that we do. We do a rapid GIMSA and a PEP stain. So the GIMSA stain is the one that we do on dry material. So that is the slide that if you don't fix it with the spray fix, the same spray fix that you use for pap smears, if you don't spray fix it, we're going to do a GIMSA stain. Now, a GIMSA stain is not a nice stain to look at. It does not highlight all the changes that we need to diagnose lesions. We like the pap stain because it's a cleaner stain. So ideally, you would, as the top left slide shows you, you would then evacuate your material onto the slide, and you then use a second slide. We're now on the top right. A second clean slide is then pressed gently onto the material or the blob that you have evacuated onto the slide, and you gently move them in opposite direction, therefore creating two slides that both have evenly distributed cellular material. Now, you can decide if the one slide is going to be a dry slide, so you would not spray fix it. The other one needs to be fixed so that we're able to do a pap stain on it. And the image on the left bottom just shows you the stains that we do. This was on site where you can quickly do a rapid GIMSA or a rapid pap stain. And on your bottom right, now it shows you the cytology. Both these images on A, B, and C are your GIMSA stains. Now, let's look at the diagnostic accuracy of your FNA or cytology. Now, when performed by trained physicians or cytopathologists or trained clinicians, it has a very good accurate diagnosis with your accuracy ranging from 89 to 98%. A lot of studies have demonstrated that sensitivity is variable, varying from 87% to a specificity of 99.5%. In expert hands, your sensitivity can go as high as 96 to 98%. I am currently running a study where we're looking at intraoperative cytology, and we're trying to actually see the diagnostic accuracy in theater looking at specificity and sensitivity, and our results are almost looking the same as what I've shown you right now. Now, its advantages is that it's a quick test, it's cost effective, like we said, no need for local anesthesia, and if we do rapid on-site assessment, we are able to actually reduce the non-diagnostic rate. So if you do the FNA and you are a cytopathologist or a pathologist and you are able to at the same time examine the slide, you therefore can go back if you need more material. We can use it when we're trying to access sites that are unsafe for needle biopsies or inaccessible, and also as a therapeutic management for palpable cyst or cystic masses, because when you're performing the FNA, you can therefore draw the fluid out. Now, it has disadvantages. It is highly operator dependent, and it has a false negative rate of about 9.6%. It has some inherent limitations, which I tend to disagree with, but we're not going to go into that today, where it's always said that it's inability to distinguish from invasive to non-invasive carcinomas. I think mostly if you're dealing with in situ lesions, it's we need an intact tissue to look at our myoepithelial cell layer and therefore be able to see if the neoplastic cells are breaking the basement membrane. And in the case of cytology, you might not be able to appreciate that. Accuracy of diagnosing lobular carcinoma is also being questioned. Now, we currently use the International Academy of Cytology Yokohama system. So this system was designed in a way that it gives you the percentage risk of malignancy. So on cytology, if your results come back as insufficient material, that patient's risk of malignancy is about 30%. If it comes as benign, their risk of malignancy is about 4 to 5%. If it is said to be atypical, you're looking at a risk of malignancy of about 51%. So that patient will obviously need a follow-up core biopsy because 50% of the chances this patient will have malignancy. Suspicious malignancy, which is category 4, the chance of malignancy or the risk of malignancy is about 85%. And here, if the patient is diagnosed with malignancy on cytology, your risk of malignancy is almost 100%, being at 98.7%. And this is just a slide showing you a C5 category where we've got malignant ductal cells in a patient who has ductal carcinoma of the breast. So that is your first one technique, which is the fine needle core biopsy, fine needle cytology. That was the aspiration. Now we're going to the second one, which is our core needle biopsy. So with the core needle biopsy, it allows a histological diagnosis of a solid lesion. It provides course of tissue using a 14-gauge manual or automated core needle biopsy. And you can see here on the image on the right, shows you the needle going into the mass, and a core will then be taken from that mass in the breast. The diagnostic accuracy here, it is associated with a specificity of 85 to 100%, with a sensitivity of 80 to 95%. And the sensitivity increases when the procedure is performed under image guidance. So when we couple it with image guidance, we can increase our sensitivity to about 99% in palpable lesions and 93% when we've got lesions that are not palpable. We usually require a minimum of 4 to 5 cores. And if you look at the sensitivity when you've got only 2 cores, we're looking at 81%, whereas it increases to 95 to 100% when we've got 4 to 5 core biopsies. Its advantages is that it permits correct histological categorization of the lesions. We are able to grade the lesion, and we are able to then perform necessary prognostic and predictive markers. And on the downside, it might require more time and training, and in some instances, applying local anesthesia, and you do not have the results immediately on site. So we don't have that rapid on-site diagnosis. Now, when would you do a needle core biopsy? When we have a suspicious mass, it provides enough tissue for us to confirm the diagnosis, and we are able to do necessary tests, immunohistochemistry, to confirm that we actually have invasion when we do markers looking at myoepithelial cells or absence or presence of myoepithelial cells, your receptor status, which is your ER and PR, and your HER2 status. I'll talk about this later on. And in palpable lesions of indeterminate nature, here we are able to also provide a definitive diagnosis. Now, this is just a slide showing you radiology-assisted guided biopsy. I'm sure the radiologists will talk about this. We've got our stereotactic biopsies, vacuum-assisted core biopsy, as well as ultrasound-guided biopsies. Now, this is how your core will look like, different from what we saw on the cytology. So why we pathologists like core or biopsies is that now we've got supportive tissue, and we are able to actually see the architecture of the lesion. Whereas on cytology, we're looking at individual cells, you more relying on the abnormality per cell to make a diagnosis. Here we're looking at the architecture. So you can see from a lower magnification that your normal architecture is distorted. We don't see the normal breast tissue, your terminal dactylobular units are not there. We're just seeing a lesion that is actively infiltrating our surrounding tissue. And obviously easy to say that this is invasive because we've got the architecture, and we are therefore able to perform our biomarkers. I think this one would be a HER2 because it's cytoplasmic and membranous stain. And on the right, it shows you molecular testing for HER2. So we can send the same tissue for HER2 testing. Now on the cytology, I said we use Yokohama and we then grade our lesion. On histology, we use your modified Bloom and Richardson. We able to look at different components to therefore give a grading, which will assist with prognosticating the patient. So we look at how the tumor basically resembles normal breast tissue. So is it forming tubules? And we give it a score. So if it's resembling the breast tissue, you'll get a lower score. And where if it's not resembling, if you've got less than 10% of tumor having tubules, you get a higher score. We also look at the nuclear size, we count our mitosis, and therefore we use the combined score to therefore give you a grading ranging from grade 1 to grade 3. Now, we also have our excision biopsies, which are also known as lumpectomies, and this refers to the removal of the entire lesion with margins of normal tissue for diagnosis and therapeutic purposes. This is performed in the operating room under local or general anesthesia, and it is indicated in patients where you've got a discordant triple test assessment. So where your clinical examination, the radiology and the histology are not giving you, a similar kind of a diagnosis, you would then probably decide on doing on an excisional biopsy. I think the surgeons will speak more about this and talk about the indications for lumpectomies. I think with the availability of more sophisticated diagnostic maneuvers like utilization of both biopsy techniques with ultrasound, we don't see a lot of lumpectomies. We actually see, I'll talk about breast conserving therapy. I think we've seen a rise in those, especially in the private sector. And this is how the lump will look like. And on cut surface, this is homogeneous, solid, probably a fibroadenoma. Now, like I said, this is just an image that shows you the grading. I think the slide was supposed to come before the excisional biopsy. This is what we were talking about, tubal formation, where we're looking at how well does the breast cancer, how well is it similar to a normal breast. So here on your far left, you would have a low-grade tumor that has more tubals. It's got less nuclear polymorphism and less mitotic count. And as you go to the right, you can see that you start to have solid tumor cells, which do not resemble breast tissue at all. Now, your incisional biopsy, also not done a lot, and this will refer to removal of a portion of the lesion for tissue diagnosis. And like I said, currently seldom required. Typical scenario would be that you have at least done 2 core needle biopsy, and you've also done this under image guidance, and you're still getting non-diagnostic results. So you might consider performing an incisional biopsy at that point. And coming towards the end of the presentation, I've spoken about the 3 different techniques, which is your cytology, your fine needle aspiration. We've spoken about the core needle biopsy. We've looked at incisional and excisional biopsies. Now, when we get this biopsies, like I said, we grade the tumor histologically. Afterwards, the importance of performing this biopsy is to actually give a molecular classification or molecular categorization of the tumor. So we started basically, I remember when we trained, we were just grading them histologically, and we were not going into molecular classification. But as we evolve, and there's a lot of changes, especially in management of this patient, going towards molecular targeted therapy, it became empirical that we as pathologists also evolve and start testing this tissue for the biomarkers that are important for therapy. So you would see that this tissues will then be tested for your receptors, your ER and PR receptors, and we then classify them according to the receptor status. So we have what we would call your luminal A cancers, which are ER positive and are negative for HER2. We've got our luminal B cancers that are ER positive, and then we have our ER negative cancers. We have our basal cell-like in that category. We have our normal breast-like, which is a triple negative cancer. So these are some of the tests that we actually will conduct on the tissues that we receive to assess, to assist with molecular targeted therapy for those patients. Now, just one slide on breast conserving therapy. Our role in those procedures would be that if we are in theater during the time of performing a breast conserving therapy, we would be looking at assessing the margins of excisions, because obviously here you're conserving the breast, you're just removing part of the tumor. And what is important is that you've got somebody to assist you to check if the margins are negative. So that can be done in theater. Assessment of the tumor bed, has the tumor been completely taken out from the tumor bed? And actually, if you're going to do a sentinel lymph node dissection, to confirm that actually what is removed is lymph node and not just adipose tissue, because sometimes tissue might be removed, and when we get to the lab, we only find that we've got only 1 lymph node or we don't have lymph node. So by utilizing cytology actually here, you can confirm with imprint smears that what has been taken out in theater is actually lymph node and not just fibrous tissue or adipose tissue. Now, in summary, adequate pathology services are essential for breast cancer control programs, and an adequate histopathological diagnosis is necessary for all patients with findings suspicious for breast cancer before initiating therapy. Thank you very much.